Hello and welcome to today's training on ICD-10. My name is Cindy Hudson and I'm the Director of Clinical Compliance with Arbor Rehabilitation. This session is going to focus on the importance of ICD-10 coding as it relates to PDPM, which goes into effect October 1st of 2019. Our objectives for this brief session are for participants to increase their understanding of why specific and accurate ICD-10 coding is so important at this time. We also want to review some things for therapists with ICD-10 coding basics, as well as increase awareness of ICD-10 coding specifics, including the seventh character and how that can impact reimbursement through case mix scoring. And we want therapists to become familiar with the diagnoses that are going to drive case mix scoring. So we know ICD-10 codes have been around for a while now, and we're doing more training on it at this point in time because under the new payment system or the patient-driven payment model, reimbursement for PT and OT is going to be based on two main areas. The first is their clinical condition, which is driven by their ICD-10 code, and the other area is their functional status, which is driven by their Section GG code. And capturing the best codes for both areas will support the facility in getting accurate and appropriate reimbursement for the services that they're providing. ICD-10 codes under the PDPM system are going to correspond to clinical categories. And those categories are going to drive the case mix score, which then impacts reimbursement. So nursing has 10 clinical categories, and PT and OT have 4 collapsed clinical categories, and speech therapy has 5 components that will impact the cost and reimbursement for their categories. So here's an example of the OT and PT clinical categories on the right-hand side of your screen. On the left-hand side, we have the nursing clinical categories. So nursing has 10 areas, and CMS has lumped or collapsed nursing's 10 categories into 4 OT and PT clinical categories. So for example, we have cancers or acute infections, and those all get lumped into medical management for PT and OT category purposes. Remember that OT, PT, speech, nursing, and those non-therapy ancillaries are all 5 pieces of the reimbursement pie. And each piece has maybe a slightly different recipe or a slightly different way that it's calculated, but they all contribute to the reimbursement pie for each individual under the PDPM system. With speech, we have 5 components, which include acute neurological conditions, certain comorbidities, the presence of a cognitive impairment or a mechanically altered diet, and the presence of a swallowing disorder. Those are the 5 areas that impact the speech reimbursement category. So if you see an acute neurological condition or a specific comorbidity or cognitive impairment, notice that they're on a mechanically altered diet or have a swallowing disorder, make sure the MDS nurse is aware of those issues before the initial reference date. We only have one chance to get it straight, to get it right under the new system. So if we see something that the MDS nurse may not be aware of, make sure we notify her so that we can capture the best reimbursement that's appropriate for that individual under the PDPM system. It's also important to be very specific with this system. Accurate coding is going to be essential to capture the best diagnosis for each person and get them into the most appropriate clinical category. So know that unspecified codes, as you read through the ICD-10 descriptors, unspecified codes often result in no category placement and therefore no reimbursement. But some unspecified ICD-10 codes can certainly be made more specific by information that we already know, such as what joint is affected or what limb or what side might be impacted. So an example of details that are going to matter, we have here S72009S, which is a fracture of an unspecified part of the femur. That's going to map or correlate to a return to provider category, which means there is no reimbursement. It's not even really a category. It just results in no reimbursement. If we can be a little bit more specific and code that same issue as an other fracture to the femur with code S72091S, that's going to map or correspond to a category for non-surgical orthopedic musculoskeletal orthopedic surgery, in which case we are eligible for reimbursement under this category. So again, CMS has a pretty involved spreadsheet that's going to indicate several specific ICD-10s and what clinical category they correspond to, and then therefore what reimbursement that individual might be eligible for. Coding tips for PDPM then, other codes, when you read through the descriptors and it says other, those codes are often more likely to be reimbursed than the unspecified codes. The medical management category typically results in the lowest reimbursement, and that may be what it is. But again, if we can find something more specific or be more detailed with our chart reviews, we might find information that could bump them from that medical management category to something that's either neurological or orthopedic in nature, and those might result in some higher reimbursement categories. Remember that from our GG training that the OT and PT case mix score for reimbursement is based upon the intersection of where they stand for functional scoring and their clinical category, especially for OT and PT reimbursement situations. Thorough chart review is going to be essential at this point in time because we've got to find the most relevant and appropriate ICD-10 diagnoses. Section I of the MDS and Section J of the MDS can impact the clinical category as well. And I know that Section I and Section J are new areas for us. Just be aware of them, and we're going to have a little bit more information about them in future slides. But just know that those areas can also impact the clinical category. And under PDPM, there's a big shift. Under PDPM, the reason for the SNF admission no longer needs to match the hospital diagnosis. So again, what they go to the hospital for, what they come into the SNF for, no longer need to match when we move into the PDPM system. We're going to talk about Section I of the MDS. So Section I has a lot of different diagnostic categories listed. And we get down to Section I 8000A, and it's a fill in the blank area on the MDS for additional diagnoses that have not been previously documented. And for our purposes, we're looking at active diagnoses in the last 7 days. So the MDS nurse is going to look back at what's been going on. She's going to fill out Section I 1000 through 7000. When she gets to I 8000, it's kind of a fill in the blank area where she can put in additional diagnoses. It does not impact the clinical category for case mix scoring for OTPT or speech, but it's a place for the MDS nurse to note the presence of speech comorbidities or the contributing non-therapy ancillary diagnoses that's going to help, again, perhaps result in a bump in reimbursement. So we've got Section I 8000A on the MDS, which is going to be potentially important for the reimbursement puzzle. Section I 0020B, which gets shortened down to I 20B, this section on the MDS, in conjunction with Section J, will drive the primary clinical category for OTPT and speech reimbursement. Section I 20B is the primary diagnosis for their SNF admit. We need to know that this cannot be a return to provider code because it's going to result in no reimbursement. So this is where your MDS nurse might come to you to say, hey, you told me whatever ICD-10 code, but it's mapping to a return to provider. We can't use it for the primary. Then we need to work with that MDS nurse, look at the chart, and find perhaps a more appropriate primary SNF admission ICD-10 diagnosis. Any diagnostic findings that we come across while we're doing a chart review, we need to make sure that the MDS nurse is aware of them as well, if it's not on the face sheet, so that we can be sure to capture the most appropriate or relevant ICD-10 coding that can impact payment. So Section J, which is going to be health conditions on the MDS, as you review a chart, watch for documentation of pain or falls, dyspnea, tobacco use, or depression, because that can impact reimbursement. Depression is actually mapped on a separate section of the MDS, but we're not looking to be MDS experts here. We just want to make sure that our therapists are looking for information that might relate to depression, tobacco use, shortness of breath, pain, or falls. Make sure that we communicate that to the MDS nurse so that we can perhaps capture any information that could impact reimbursement. Also, major surgeries that are performed within the past 100 days, if we find that information on the chart review, make sure the MDS knows about it as well, if it's not elsewhere noted, because that can impact or bump the reimbursement as well. So again, we don't want to miss any opportunity to upgrade clinical categories. We don't want to leave any dollars on the table. If we see something in the chart as we're looking through, make sure the MDS nurse knows so we don't miss an opportunity. So be on the lookout for additional opportunities to capture some potentially important clinical categories that can impact reimbursement with the new system. We've got speech comorbidities, which are diagnoses that can indicate an increased care for that individual, therefore increased costs. And we have non-therapy ancillaries, which are either comorbidities or conditions or medical supplies that indicate increased care for that individual and increased cost. And CMS is finally going to improve reimbursement to the facilities for taking care of residents that have these comorbidities or clinical conditions. So again, we want to help our facilities not leave any dollars on the table. Carefully look at the chart to look for diagnostic information related to your discipline and look for other clinically significant conditions. Again, we want to capture the non-therapy ancillaries, speech comorbidities, and any recent surgeries that might impact the reimbursements for our facilities. So we've been talking about speech comorbidities, and here's what they actually are. That includes these 10 main areas, such as aphasia, traumatic brain injury, speech-language deficits. But what you need to know is that there are only select ICD-10 codes that are going to qualify that diagnosis as a speech therapy comorbidity. Not all will necessarily map or correspond to one of these comorbidities. But it's important for now to note that if you see something along these lines, notify the MDS nurse, and she can see if there is an ICD-10 code that's going to map to that comorbidity and capture more reimbursement dollars when it's appropriate. That's how the speech comorbidities are going to work. For the non-therapy ancillaries, okay, there are actually 50 non-therapy ancillary qualifying areas. And not all of these qualifying areas are listed on the slides that you're seeing in this presentation today. You're going to see about the top 15 to 20. But for example, you want to take note of things like COPD. COPD is going to result in 2 non-therapy ancillary points being granted to this individual. When we look through the whole list, what they're going to do in these charts from CMS, the points from each of the above areas are going to be added up and can impact the case mix index. So if they get 2 points for this, 1 point for that, 1 point for something else, they could have a total of 4 points, which would then correspond to a potential bump in the case mix index. Be aware that such non-therapy ancillaries as comorbidities for morbid obesity, end-stage renal disease, cardiorespiratory failure, and shock, they all have points associated with them for non-therapy ancillaries. We don't want to overlook those potential points because that can, again, result in a bump in the reimbursement. But going back to the basics for ICD-10 coding, that 7th character is going to be real important for coding accuracy. Know that the fracture ICD-10 codes have a slightly different 7th character than the other codes, so they might look a little bit different as you pull up the list in Rehab Optima. For the treatment diagnosis, you may want to include the main code indicating the need for therapy when possible, and include deficits code when appropriate. So for example, we have S72.0525S, femur fracture sequela, and R26.2, difficulty walking. Just those 2 codes alone give a real clear clinical picture that perhaps physical therapy is addressing the issue of difficulty walking related to that femur fracture. Sequela codes frequently need a deficit code as well to help kind of clarify what it is that's actually being treated. So we have the 7th characters. Okay, in our little picture here, we do have 8 of the dwarves. They pictured Doc twice for some reason. 7th characters. Okay, so sequela is the main one that we're going to be using, or S is how it's coded, and it's used for complications or conditions that arise as a direct result of an injury or an incident. Sequela describes the residual effect or functional impact of a complication or condition. And again, there's no time frame for this, which is probably a good thing. It's going to be the one that we're most often going to use when appropriate. The 7th character for subsequent encounters is D, and that's going to be used to describe encounters after they've received acute active treatment for an injury, and they're getting routine care or follow-up. So this is often done by the physician or the physician's assistant. It is a term that can indicate medical follow-up for an issue. It's not typically going to be used by therapists in the SNF setting. We're not usually the ones providing those subsequent encounters. The 7th character A is for an initial encounter. It's used to describe that initial visit for an injury or condition while they're getting active treatment for that injury. It's typically done at the emergency department or in the doctor's office. It's not to be used to indicate therapy's first visit with a patient. Okay, that's the initial encounter. Consider it from the patient's perspective, not the therapist's perspective. By the time we're seeing them, it's not going to be the individual's first encounter to address the issue that's going on. So again, we're not going to be using that initial encounter 7th character. What you want to do is confirm with your MDS nurse all of the diagnostic coding issues, including the 7th character. Note your findings, discuss it with the MDS nurse, make sure that we're using what they agree to be used. Note that at this time, the facilities may contract with certified ICD-10 coders who will advise the facility of the best and most appropriate codes to use for any given individual. So we just need to coordinate our findings with the MDS nurse. Know that that MDS nurse might be coordinating that information with a certified coder to choose the best and most appropriate ICD-10 code. Z codes. So aftercare Z codes should not be used for aftercare for conditions such as injuries or poisonings, because in those situations, 7th characters should be used to identify subsequent care. So a Z code example, for a follow-up care of an injury, you want to assign the acute injury code with the 7th character code, usually sequela, for our situations. Based on those guidelines, if the surgery resulted from an injury that allowed for the 7th character, you would use the original acute injury code with the 7th character S. So in this example, a rotator cuff strain, sequela, S46.011S. In other words, you do not use the Z codes when fractures have been surgically repaired. Use the acute fracture code with the correct 7th character. No aftercare Z codes for the acute injury, i.e. a fracture, but you can use an aftercare Z code with diseases such as arthritis. So for example, a hip replacement, we're going to look at it kind of comparing two different ways of looking at a hip replacement. With arthritis, a joint replacement, again, due to arthritis, could require 2 ICD-10 codes. The aftercare of the joint replacement, which is Z47.1, and the identified joint, the presence of the left artificial hip. Again, the logic is that if they had arthritis of the hip, they get a total hip replacement. They no longer have arthritis of the hip. They just have aftercare of the joint replacement, and they have the presence of an artificial joint. However, a hip replacement after an injury, okay, when they've done a total hip replacement after an injury, then we're going to use the S72.141S as an example, or a displaced intertrochanteric fracture of the right femur, the sequela, and the presence of the artificial hip joint, that Z code. Your MDS nurse might also choose to use one of the fall codes that are in the W series. Again, that would be at the discretion of your MDS nurse. We're going to talk about the weakness codes for a moment. So M62.81, M codes relate to diseases of the musculoskeletal system and connective tissues. They also relate to the weaknesses of conditions such as rheumatoid arthritis, osteoarthritis. Those non-neurological weaknesses are the M62.81 codes. R53.81 is a chronic debility code. We're not typically going to use this if there's something better to choose from. So for example, if there's a hemiplegia code, we might choose that as opposed to that chronic debility code. R54 is defined as frailty or age-related weakness, and this might be a more likely choice for a generic weakness code with our population. So either M62.81 if it's appropriate, or R54 are going to be our more likely generic weakness codes. Be aware that common treatment diagnostic codes such as R26.89 for gait and M62.81 do map as a return to provider code, so they cannot be used as a primary reason for the OTPT SNF stay. So if our MDS nurse is trying to put those generic weakness codes into the I-20B section of the MDS, it's going to come up as a return to provider. We need to go back to the chart and find something more appropriate. When possible, it's advised for speech therapists to choose from the I-69 series of codes versus the R13 series of codes. So for example, I-69.391, dysphagia following a cerebral infarction, maps to an acute neurological clinical category, whereas R13 maps to a return to provider code and therefore is not eligible for reimbursement. Some final thoughts. You want to scroll through the entire list of ICD-10 codes in Optima to choose the most appropriate, remembering to choose other versus unspecified if you have no better options. Be specific when you can. If you see something, say something to the MDS nurse. Make sure that she knows what you found in your chart review, whether you're looking at a radiological report or maybe some therapy notes. Make sure that you say something to the MDS nurse in case there's something going on she's unaware of. We're all responsible for making sure that we're not leaving dollars on the table by missing some potentially important ICD-10 coding information. When we're choosing an ICD-10 code, remember to be as specific as possible. So contact us information, alert your area manager or regional director to some specific concerns related to your facility. If you've got general clinical questions related to ICD-10 or PDPM, feel free to contact me. There's my email and my cell phone information below. Thank you for your time and attention to this session today. I hope you have a great rest of the day ahead.